Hey NCS podcast listeners, this is your host Fawaz Al-Mufti. Welcome to another episode of the Neurocritical Care Society podcast's Newsflash, New Science in Neurocritical Care. We're excited to announce that for the first time we'll be podcasting directly from the NCS annual meeting in beautiful Vancouver, British Columbia. Highlights from hashtag NCS 2019. I hope you enjoyed this episode and thanks for listening. This episode is sponsored by the TTM Academy at Penn Medicine, an educational initiative to improve care for patients following cardiac arrest and other neurocritical care illnesses using targeted temperature management. Find out more at penttm.com.
Hello, I am Storeen Shepherd, Assistant Professor of Neurology in the section of Neurocritical Care at Rush University Medical Center in Chicago, Illinois. And we're coming to you from the Neurocritical Care Society Conference in Vancouver, Canada. My guest for today's episode is Theresa Human, clinical neuroscience pharmacist at Washington University in St. Louis, who was one of the speakers at a section on an emerging therapy called CAR-T therapy, presented here at the annual conference. How are you doing, Theresa?
I'm doing well. Thank you so much for having me.
No problem. So, over the past several years, immunotherapies that enlist the patient's immune system to attack different diseases have become more and more prevalent, and it's an exciting new area, really, of medicine. Can you explain what exactly is CAR-T therapy?
CAR-T therapy is also known as chimeric antigen receptor T-cell therapy, is essentially a potent immunotherapy that has been initiated initially in hematopoietic malignancies to target those. However, these therapies are being evaluated in many other areas as well outside of hematopoietic malignancies and are finding that they're very effective. What CAR-T cell therapy is specifically is the patient's T cells are harvested. There is new research looking at autologous T cells from donors, but at this point, most of the T cells are harvested from the patient specifically. Those T cells are isolated and genetically altered to attack a very specific receptor or antigen in the body, and that's typically a malignant cell. Those cells then, once they've been genetically altered, are then allowed to grow and then are preserved for the patient then to have the infusion of those new T cells. In the interim, prior to those new CARs being infused into the patient after they're grown and expanded, the patient will oftentimes undergo lymphodepletion with doses of chemotherapy to reduce the number of their own lymphocytes and T cells. And therefore, when the infusion of the CAR-T cells are there, it allows for better expansion and efficacy for those new CAR-Ts to effectively attack the cancers.
Okay, so just for our audience, we've said CAR-T, but we'll take a step back and actually, what is CAR-T? It's an acronym and it stands for
Chimeric antigen receptor therapy.
Okay, awesome. And in these hematologic malignancies, is CAR-T cells, are they first line treatment now? Is it second line? Is it third line?
So the CAR-T therapy currently is used in patients as a last line option. However, and that's because it is relatively new, it's extremely expensive, and we're not sure exactly what the long-term outcomes are. We're infusing T cells into these patients that are genetically altered. However, and it is appearing to be very effective in putting many of these patients into remission. The problem is that this is a living drug and it will continue to work within the patient's system. And we don't know what those long-term side effects are. And so at this time, it is sort of a salvage therapy. Salvage therapy also, though, being you have to be relatively well to even be considered for this therapy. You have to have pretty good kidneys, you have to have pretty good lungs, you can't be too old or too young. So there are a lot of other considerations that go into this as well.
Okay. So you mentioned the long-term side effects, but what are some of the more immediate side effects?
So there are a host of side effects that we're seeing among patients that are being infused with these T cells. The first thing is, though, that not every T cell or CAR that's been designed cause all of these side effects necessarily. There have been several generations of CARs that have been designed, and as we move through the generations, we are becoming less toxic to the patient and more effective towards the cancers typically. So there's a lot of things that go into the construct of the CAR that identifies and are directly impact the toxicities. The toxicities, however, that we're really seeing, the biggest and most prevalent one would be called CRS, or cytokine release syndrome. And in these patients, we typically see it. They're at risk for this cytokine release syndrome and if they have a high tumor burden, if their dose of Karti is quite high, if they have a concurrent infection. The CAR construct puts the patients at risk for this as well. And what cytokine release syndrome is and really it's going to happen in every patient. The question for cytokine release syndrome is, when is it going to happen and what is the severity of the cytokine release syndrome? Because as we're infusing activated T cells into the patient, that is what the job of the T cell is to cause the cytokine release. And that's really some of the efficacy by with which the drug will work, but is also the pathophysiology for cytokine release syndrome. Typically starts with the hallmark sign of fever, and then is really any host of things that you can only imagine that go along with a cytokine storm. The symptoms of cytokine release syndrome look very similar to a patient that is septic, hypotension, where you would require pressors. You would certainly want to ensure that they were fluid resuscitated in the process, and definitely using Tylenol would be an option in those patients and highly considered to treat the fever. And after that, then we start looking for things like renal dysfunction. There are some toxicities that can occur everywhere else in the body as well. Cytokine release syndrome is typically seen within 1 to 3 days or so after the infusion of the CAR-T, and typically goes away within the first 7 to 9 days with treatment.
So I'm a neurointensivist. It sounds like with the cytokine release syndrome, some of these patients will need an ICU if it's really severe. But why would I, as a neurointensivist and not, like a medical ICU doctor, why is it important for me to know about CAR T cells and their side effects? Are there any neurological side effects that can occur?
Absolutely. And that is really why I think we would advocate in a lot of these patients, especially with severe cytokine release syndrome, that they be placed in an area of neurocritical care if possible, or in a neuro floor where the nursing staff and the physicians are able to identify these neurologic toxicities, which is sort of the second very dangerous side effect of these CAR-Ts that we're seeing. So these neurotoxicities, otherwise called ICANS, which stands for Immune Effector Cell Associated Neurologic Syndrome, where these patients have various degrees of neurologic symptoms that range from, and some of those symptoms being more global and some of those symptoms being more focal. Identifying those symptoms, however, is very important because acute treatment is necessary in order to obliterate the neurotoxicities. The malignant cerebral edema is certainly one of the most feared consequences of the neurologic toxicities that we see after CAR-T cells are infused. And definitely with these patients, it's a very rapid progression from mild symptoms oftentimes, and maybe mild symptoms of edema, to herniation and death. So that's why it's very important. The other symptoms, however, that are maybe not as concerning, but certainly still worth mentioning and talking about the treatment thereof would be aphasia, would be one of the main neurologic side effects that we would see in these patients. And this aphasia can be anywhere from word finding difficulties all the way to abulia and global aphasia. And these patients sometimes can be abrupt in onset and sometimes can be over a period of time. Those that appear to be abrupt in nature can oftentimes mimic a stroke, which most of the literature at this point looking at pathology does not appear that these toxicities are focal in nature, and it's usually not, in fact, an ischemic stroke. There's something else going on pathophysiologically that's causing these global symptoms. Dysgraphia is another one of the common side effects that we see, and often one of the first. Escherichia is also one of the very first and tremor side effects that we see. Headaches are another neurologic finding that we have, tend to be quite mild and almost tension-like in the presentation. We certainly can see other neurologic side effects, including seizures, which may or may not actually be that common, and I think some of the literature is still sorting that out, if these changes on EEG are in fact seizures or not. And then definitely as the ICANS or the neurologic toxicities progress with time, there are risks then in the prolonged state, and that typically is after about 2 weeks or so, we can start seeing risks, cerebral hemorrhage and or ischemic strokes.
So if I have a patient in the ICU that is developing some of the more severe neurological symptoms and side effects, are there any medications that I can give to try to prevent worsening neurologically? Or should I just give the patient steroids because that's what we always do in the ICU? Is mannitol still effective?
So with these neurologic toxicities, they oftentimes go hand in hand with cytokine release syndrome. And as we mentioned that before, cytokine release syndrome is often a precursor, not in all cases, to the neurologic toxicities. When we're treating the cytokine storm, so to speak, we're using agents such as tocilizumab, which is a receptor, an interleukin-6 receptor antagonist. So by blocking one of those major pro-inflammatory cytokines, we're in fact hoping to abort or stop that release syndrome happening with the patient. We'll also, in these patients that have cytokine release syndrome that are moderate or severe, oftentimes we'll give doses of steroids as well, because that will officially blunt the T cells. There are other agents that are being investigated currently, such as siltuximab, which is another interleukin-6 and may actually be even more effective than tocilizumab in the fact that it not only binds to free interleukin-6, but also to membrane-bound interleukin-6. By giving tocilizumab in patients with CRS or cytokine release syndrome, we may actually be increasing the risk of patients to have subsequent neurotoxicities. That's the theory, is because by blocking with toci, you block the receptor. And when you block the receptor, you allow for higher serum levels of interleukin-6. So in patients then that have been treated for cytokine release syndrome, we would need to be very cautious about monitoring for the neurologic sequelae and side effects, again, with malignant edema and herniation being the worst outcome that we could have. In these patients then, the drug of choice would be high-dose steroids. We love steroids in the neuro ICU, so high-dose steroids in patients with severe neurologic toxicities would be important. Other options would be dexamethasone, 10 milligrams IVQ, 4 to 6 hours could be effective as well in those patients. The patients that have malignant edema, however, you may consider osmotics, which certainly could help. You could use either mannitol or hypertonic saline, whatever your choice was based on the patient's necessities. Other items that you might consider would be anakinra, which is an interleukin-1 receptor antagonist, which has been shown in mouse models to actually abort neurotoxicities. Siltuximab, again, because it gets both the membrane-bound and free interleukin-6 could be effective, as well as anti-thymoglobulin, rabbit, is the one that's really been evaluated in case reports in patients with those to abort in really all of the T cells and their efficacies. And that seems to potentially have worked in one patient that had rapid edema with impending herniation and appeared to reverse those symptoms. So at this time, there is other information data looking at other agents that may be more effective, but at this point, high-dose steroids would be your drug of choice for any of the neurotoxicities. The other thing I would like to comment on is I think because we're treating this neurotoxicities much earlier with steroids, we're also seeing less long-term sequelae. I would not be afraid at this point to give steroids in any patient. I know that there are some controversies as to whether or not steroids will actually reduce the long-term efficacy of the CAR against the cancer. However, again, data is limited and there's a paucity in there. However, there seems to be data both ways that it might limit the efficacy. However, there's some refuting data that's been coming out saying that it does not. So at this point, giving steroids would be a very important early intervention for any neurotoxicities.
Okay. Thank you, Teresa, for taking time out of your busy schedule today.
Thank you so much.
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawazal Mufti, Romani Baloo, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Sternnezer, and Chris Zammit. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau, Angel Gindel, Sarah Memon, and Becca Stickney. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcasts. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawazal Mufti, and thanks for listening.